palpitation that manifests with a PE would be a feeling of sudden shortness of breath, some chest pain, leg pain or swelling, increased respiratory rate and heart rate, and the possibility of coughing up blood. The body attempts to compensate for the reduced blood flow by increasing the heart rate and increasing the respiratory rate, but this is not suitable and is definitely an emergency. If a patient is showing some of these symptoms, evaluation should be completed as soon as possible. A CT pulmonary angiogram, as Danny was talking about, may be completed for PE confirmation, but a VQ scan or even an echo may be used as a second-line diagnosis if needed. If a patient has a history of long-term anticoagulation use, reevaluation appointments should be scheduled to ensure that the benefits are still outweighing the risks with the current prescription that they're on. Recurrent venous thromboembolisms are associated with increased morbidity and mortality, and every patient individual is going to be evaluated for the risk of reoccurrence, and every person's going to present differently. So when prescribing anticoagulants, they're ensure there's not a larger risk of major bleeding than there is a risk of DVT and PE. It's kind of the balance act of it. In the reevaluation, completing a bleeding risk assessment is important to monitor for bleeding complications that may be exacerbated with anticoagulation therapy. Over time, the patient's risk profile will change and may warrant an adjustment in their current anticoagulation regimen. Patient education becomes very important during these evaluations to ensure they stay on top of their appointments and also to make sure they understand the risks associated with anticoagulation therapy. And then lastly, when a patient has potential risks occurring in their lives, Danny kind of touched on this as well, pregnancy, birth, and surgery, they should consult with their doctor to create a management plan for their disease as needed. So in pregnancy, factor V Leiden can lead to complications such as miscarriage, stillbirths, placental abruptions, early onset gestational hypertension, HELLP syndrome, and or fetal growth disturbances. And so advanced maternal medicine may be consulted due to these individuals having high risk factors that could lead to complicated pregnancies, births, and even postpartum. And then patients who plan on having surgery are also considered high risk due to the increased risk of blood clots. So doctors may recommend and prescribe anticoagulation therapy, even if they were not previously on any, to minimize the risk of blood clots. So they should still be closely monitored. And then again, some other recommendations may be the use of leg compression devices and early mobilization and close monitoring. So when the patient is inpatient, so admitted to the hospital, and then when they're discharged and living their everyday life, they have some different management plans. So patients with factor V Leiden mutation may require a hospital admission if they have a blood clot or if there's concern for a PE or if they have an active PE. While being admitted, there'll be multiple different steps completed before sending them home. The patient will require treatment and monitoring for blood clots, which may consist of the treatments that were explained above that I kind of went over. With a diagnosis that lands a patient in the hospital, the goal is to really return them to their baseline. Baseline is different and really relative for each individual, and a management care plan with goals for discharge should be made. When preparing for discharge, the patient should be educated on what their everyday care will look like for their disease management. Again, every patient's going to be different. So when they're out of the hospital, these patients must create lifestyle habits that minimize blood clots. So this can include weight management with regular physical activity, smoking cessation, avoiding long periods of immobility, kind of just keeping that patient moving. You can see on the right-hand side of the screen here, these are different factors that can lead to blood clots in these patients. So these patients should also have routine follow-up appointments with their doctors to ensure they're being managed correctly, changing medications as needed, just keeping up on blood work, making sure that everything's within defined limits for them. And then depending on changes in the patient's life, they may require changes in medications as well. Consistency in medication is also very important and something that should be highly pushed on the patient and educated for them Anticoagulation medications are really important when prescribed, especially for the patients with the factor V Leiden mutation to minimize the risk of DVTs and PEs. And then these are references. I didn't know if you had any questions for us, Miata.
Yes, I do actually. So does the clot happen in the same place every time? Because I know you described it happening, I guess in the right vena cava, right? So it
Yeah,
will be
good.
every time in every person.
So they typically happen, it's part of like the deep vein thrombosis. So that's either in the legs, but it can happen in your arms too. So it would depend if it was in the legs, it would follow the inferior vena cava. So that's always going to be how it works because that's, what takes the oxygen poor blood back to your heart is the inferior vena cava or the superior vena cava. So if it's in your arms, it'll follow the superior vena cava. If it's in your legs, it'll go in the inferior vena cava, but it all ends up in your right atria, your right ventricle, and it doesn't get caught up until it gets in the smaller vasculature of the um, pulmonary veins
Okay,
or pulmonary arteries. I'm sorry.
that makes a lot of sense. And then how long does it take for your heart to go into failure when a pulmonary embolism happens? I don't know if you covered that.
Yeah, I didn't cover it. I don't know if Abby has an answer for this. I think it depends
Like it's
mostly on.
days,
Go ahead.
weeks, or years.
Yeah, I think it depends mostly on the clot burden because people can have like diffuse pulmonary emboli that are like really small, but out in the periphery of the lung vascular, yeah, the vasculature, pulmonary vasculature. But if you have like a saddle PE that's occluding the large arteries leading out from the heart, it can be in seconds. Like some people will have their right heart just give out immediately, while other, it totally, to me, I'd have to look up more information on that for you. That's a great question, but I think it is mostly to do with the clot burden.
Okay.
Yeah, I feel like definitely the large PEs, I as a health like bedside, that's can be one of the scariest things is that how sudden it happens and how quickly things can go bad. But definitely PEs can happen over time, especially with this mutation that you've talked about. DVTs can form quicker and more often, leading to higher possibility of PEs occurring. So I think that it really just depends on the person. And I mean, if they have increased levels of DVTs, it's just kind of a matter of time if uncontrolled, I believe.
Okay, thank you. Okay, my last question is how long does it take to do the well score and like that whole process? Because during the time for, you to determine what's going on with the patient, is the patient getting any treatment or are they just like, you know, crisis or something? Like what's going on at that point?
Yeah, so the well score is just essentially it's like a going through their medical history and evaluating what they're presenting with at the moment. So it'd be a matter of minutes before you had like a good well score, and then the same thing with um the well, what is it, the PERC score. So it's just looking at their chart, looking what their recent history was, and evaluating their current presentation. So minutes.
Okay. Okay. Cool. I don't have any other questions. You guys did a great job.
Thank you. Man, you hit us with 3 questions. We only hit you with 2.